Hello everyone, it's great to be here. It's really a distinct honor for me to be in a room with so many people who are really change leaders. I've been quite impressed and actually quite delighted to hear some of the conversations that have gone on in this room over the last 2 days. I haven't been at all the sessions, but I have to say, when I've been here, it's been quite remarkable. I want to start off by acknowledging where we are today. And where we are is on the traditional territory of the Mississauga of New Credit, the Haudenosaunee people of Six Nations, and also the Attawandaron people, who are formerly known as the Neutral peoples. And Toronto has always been a gathering place. This is the biggest city in Canada, and it's always been a center, a meeting place, where people have come together for millennia to share ideas, to accommodate one another, to think, to plan, to change. And it's really important that we be part of that. And we know that healthcare is an enormous undertaking in this country. It's political, it's socioeconomic, and it's a challenge across all of our society. And perhaps nowhere is that challenge greater than for Indigenous people. And having them as full partners in that undertaking is a really important step. And partnership, in a way, is what I want to talk about here today. One of the topics, you'll notice that the topic, and I have the full disclosure here, I'm actually sort of like my daughter, who works often as a substitute teacher. I'm a substitute speaker. The person who would have been here, had her schedule not been so intense right at this time, is Gertie May Muse, who is my partner. Normally she's the Associate Director of the Southwest Aboriginal Health Access Centre in London, based in London. She's currently seconded to the Association of Ontario Health Centres to lead out the response to Patients First. And so as you can appreciate, the kind of conversations we have around healthcare are pretty intense. My background is in communications, and so language is very important to me. Language is a tool that everybody in this room uses. And I have a special relationship with language, and I tend to sometimes want to take words apart and look at them and try and make sense of them. And one of the words I want to look at with you today is empowerment. And to be honest with you, I have a problem with empowerment, the word. It's what I like to call a transition word. And what I mean by transition word is that when we're trying to affect change, we need to get from one place to another. We need to find the language that helps us to do that. And in the last 30 years, 40 years in this country, we have seen enormous change, social change. We've changed as a nation. We've changed as people. And we need a language to help us do that. But the trouble is sometimes we can get stuck on a word. And that's when it becomes a buzzword. And we need to be able to get off certain words. And we need to understand, well, what is it about that word that might be problematic? And one of the problems with that word, empowerment, is that it has certain facets embedded within it. And one of those is the notion that somehow we can help give power to someone else. And there's an assumption built into that first of all, that an individual or a whole community even perhaps doesn't already have power, doesn't already not have the authority to do what they need to do for themselves as a community, as a people. And so using words like empowerment can be very problematic when you're talking with Indigenous peoples. Now, I'm not here to speak for Indigenous people. I am not Indigenous. My partner is. My children are First Nations through my former marriage. But I want to speak about our relationship with Indigenous people. And as a person who's worked for a number of years around issues of Indigenous health, I want to be able to share with you what I know. And I expect that some of you right now may be feeling, well, where do we go? If we can't talk about language like empowerment, what are we supposed to say? Well, I'm going to help you get there if I can today. And there's a pathway to a better relationship that I'm going to help you to find. Because we know we all need to find pathways to better patient experience. If there's one thing everybody in this room agrees on, we want to change how patients experience healthcare. And that, of course, includes Indigenous people. So what I'm going to get to talking to is not about empowerment, but rather the role of self-determination in relation to Indigenous people. Because what we're really talking about is the fact that to some measure we don't fully understand who Indigenous people are in this country. Most of us, what we know about Indigenous people comes from media, from the limited history we've ever learned about Indigenous people, from Hollywood representations of Indigenous people. There's an author out of the U.S. by the name of Paul Chet Smith, who wrote a lovely acerbic little book called Everything You Know About Indians is Wrong. He is the assistant curator of the Museum of Indian Art at the Smithsonian. And in that book there's this fabulous picture. And the picture is of Geronimo. Now everybody here in this room pretty well, I'm sure most of you have heard about Geronimo, the great Apache warrior, right? Well, in this picture, Geronimo is sitting in his 1920 locomobile in full suit and top hat and getting ready to go to church with one of the other chiefs. Because apparently Geronimo actually was a devout Catholic and went to church every Sunday in his car. That's not the image we tend to have of Indigenous people. And Tom King here in Canada recently wrote another book which I really recommend all of you read, and that's called The Inconvenient Indian. And he really speaks very directly about the relationship between Indigenous people and the rest of us. So when we think about Indigenous people, for most of us, I'm sure, certainly here in Ontario, and I've lived from one end of this country to the other, and I think it's a common understanding, some measure. Here in Ontario, we think of Indigenous people as up there somewhere, north, out there somewhere, around north. Places like Attawapiskat, small reserves, living in horrific conditions. And we often say, oh, Jesus, we could only get all those Indigenous people down here in the cities and move them off the reserves and change their lives. Everything would be great. Well, that's a very incomplete picture. Yes, there are reserves. There are communities like Pakanchkam and Attawapiskat, Moose Factory, places where Indigenous people live under conditions that most of us would find impossible to endure. But the reality is, here in Ontario at least, the majority of Indigenous people don't live on reserves. They live in southern Ontario. They live in centres like Toronto, Hamilton, Timmins, Sudbury, Thunder Bay, London, Ontario, Sarnia. They're scattered throughout our urban centres. Just like everyone else in this country, Indigenous people have, over the past numbers of decades, migrated out of the rural areas into the urban centres, looking for a better life, for a better opportunity. And yet, as you're going to see from some of the data I'm going to provide for today, that hasn't happened. So I'm not saying there aren't problems, there aren't issues that Indigenous people face. I'm saying that the problems sit here, largely right in our urban centres, places like Toronto. And one of the key things that I want to share with you today, and I'm sure many of you are aware of, is the fact that we have very little data related to population health for Indigenous people. We have some notions, we have some ideas about it, but the fact of the matter is their data is just not there right now. And there's a host of reasons for that. Part of that is historical. If any of you are aware of the history of Indian hospitals and some of the things that happened during the tuberculosis epidemic decades ago, Indigenous people in this country were mistreated, maltreated, and really abused. And that included our healthcare system. That included our doctors, our medical system. They became subjects for research for the betterment of non-Indigenous people. So as you can well understand, Indigenous people have a great reluctance to participate in research, in data gathering, and data collection. But that's changing because there are Indigenous people who are now conducting that research. One of the key people who's doing that, who's probably at the forefront of Indigenous population research right now, is Dr. Janet Smiley here in Toronto. I don't know if any of you have heard of her. She is at St. Mike's Hospital, the Well Living Center, and she has written a number of pieces, conducted a number of research projects into population health. And I'm going to share some of the data with you because I think it's really important that we understand just where Indigenous people are in the healthcare spectrum. And the example I'm going to take is from Hamilton. That was the first study. The project is called, and it's still an ongoing project, it's called Our Health Counts. And the first one was launched in Hamilton in December of 2011. Based on statistics that were available, there was an estimated 13,735 Indigenous people in the Hamilton region. And that is based on census data, and as has been shown from the research, that's vastly understated. That number represents about 2.8% of the population of Hamilton, and I want you to hold that number in your mind, 2.8%, because I'm going to come back to it a little later, and I'm going to show you why the data is so startling at some measure. As many of you are probably aware, the population in Hamilton, the Indigenous population in Hamilton, is much younger than the general population. The fastest growing demographic in this country continues to be Indigenous people. The average age is well below the national average. And one of the key findings that came out of this was that it supported the general community, Indigenous community perspective regarding their poor health status. And the data is significantly higher than what was known to date or estimated to date from previously available data. It's disturbingly higher. In the survey, 790 people were surveyed in Hamilton. That included 554 adults and 236 children. And one unique outcome from this is that 92% of the participants, because of the work done by Dr. Smiley and her team, have agreed for the first time ever, 92%, to have their health data connected to the existing systems. That was missing. So here we are planning to engage to improve the health experience for people. We don't even have the data until now. We're just beginning to get that data. What stands out, and I've heard the term social determinants used here, it's one we all recognize that impacts health beyond pretty well any other measure in this country. And poverty and housing are certainly two key factors there. In this survey, it was revealed that over 90% of the participants had moved in the past 5 years, some multiple times. There's great instability in housing. 63% of the people surveyed had to give up things like food to pay for housing. And as you can well imagine, that kind of data produces other data. High levels of stress, high levels of poor health outcomes, high levels of chronic disease. Education and employment, also another socioeconomic factor, is disturbingly negative when we look at the experiences. So we have Indigenous people move to urban centers. They're not on the reserves anymore. So how come their socioeconomic picture is not changing? How come that's not the solution? Get them all off the reserve. Everybody says, let's move them all out of Wapaska. It'll all be fine, just living in the wrong place. Well, they're living in some of our biggest urban centers. And yet, the survey in Hamilton indicated that 92% of the Indigenous population is living below the poverty line. A similar survey coming out of Toronto by Dr. Smiley's team indicate that 90% of Indigenous people here are living below the poverty line. 90%. We get disturbed when we hear that 10 or 15% of our population are living below the poverty line. Can you imagine what it would be like to be part of a community where 92% are living below the poverty line? And that shows up, as I said, in chronic disease, disability, They have a greater health burden. It spreads across age spectrum. Young people, old people alike, all report on chronic disease outcomes, impacts. 16% of the study, the people who participated, report having diabetes. That's 3 times the general population. 3 times. And 26% report having high blood pressure. And the indications that for most of the people who participated, they don't see their health as very good. It's fear the poor, is how they describe their health. Women particularly showed up in the negative numbers in this study, as you can well expect. Women's health issues are often more complex, in part because they're less understood and have been less researched and less supported. So where does this come from? Well, there's a historical factor, of course. Many of the people who participated reported having been at the residential school system. We've heard about that in the media, I'm sure. 6% were actually students at the residential schools, even though they've been closed for decades now. The last one closed, of course, not that long ago in Saskatchewan in the 1990s. But 40% had a family member. So this continues to impact. The intergenerational trauma of residential schools still continues to impact this population. Violence is also a problem within the community. In fact, the neighborhoods they live in, the vast majority of the Indigenous population, compared to any other population, lives within the poorest areas of Hamilton. And for the people who live in those areas, 95% of the violence they encounter happens in their own neighborhoods. So where's a safe place? How do you find safety? And as we are all too often aware, there's a high level of lateral violence within the community. People under stress act out. They have to. It's a normal human reaction. And First Nations, Indigenous people do that. And this population, by the way, just for clarification, is about First Nations. And Indigenous covers a lot more ground than that. And as some of you may be aware, for Indigenous people, we're talking about Métis, Inuit. But these are First Nations people who participate in this study. So when we're looking at addressing these problems, the question then becomes, to my mind, is what's the model of care? What's an appropriate model of care that we want or hope to see Indigenous people participate in? We know we have a deserving picture here in front of us. But I'm hoping, and I expect that knowing this actually motivates each of us to act, motivates us even further to act, to do what we can, to figure out, okay, what is it we can do? How do we help support change? How do we change this picture? How do we help do that? Where's our place in this? And it's probably a good idea if we stop and think about, well, how do we understand health? Do we understand health the same way that Indigenous people do? And I think that's probably something we really need to seriously look at. We tend to look at the patient. Sometimes we have family participation, and certainly there's been community engagement. I've heard so much about community engagement here in the last couple of days, and it's wonderful to hear that. It's such a critical piece of changing the landscape of healthcare in this country. But for Indigenous people, the core of a holistic model of care is the individual sitting at the center, surrounded by family, community, and nation. And that doesn't change. So when we are looking to engage with Indigenous patients, we have to be prepared to engage at a much broader scope. It's a concept that incorporates the spiritual, the physical, the mental, and the emotional. It's a much broader concept of health and wellness. And wellness captures many, many different issues in Indigenous communities. There's a balance. The expectation is that there will be a balance between those 4 elements of wellness. And yet for the people studied in this, or who participated in this this research, our health counts work, 42%, only 42% felt in balance at any time. In fact, the vast majority felt out of balance most of the time. And being out of balance tends to impact how you behave. There's higher incidence of alcohol consumption, cigarette smoking, all things that impact health. It's a catalyst, right, that drives some of the outcomes. But there's lots of room, as you can see, for improving the patient experience for Indigenous people then. And one of the other pieces that came out of the study in Hamilton was an urgent need for access to healthcare. The reality is, they aren't having an experience. There's no experience to improve. Their experience is one of not having healthcare. 40% of the participants rated their ability to access healthcare at all as fear to poor. And there's lots of barriers. Waiting lists, we all hit that one. But it's also, because of poverty, things like access to transportation. They can't afford direct costs. They don't have the resources to afford direct costs of healthcare. And one of the things that's happened that changed the landscape of healthcare in Ontario, in particular, is this migration. We tend to think as the federal government as being responsible for Indigenous healthcare. And, well, if you're living on reserve, there are resources. The minute you move off, that all goes away in large measure. Yes, there are some non-insured benefits that Indigenous people have. But like the rest of us, Indigenous people have to try and access the mainstream system. Ontario recognizes that, and because of that, they are acting to change that experience, to increase funding. They're taking up the slack from the feds in a big way. In the recent announcement, under the Patients First, the provincial government announced $250 million in Indigenous healthcare funding to be rolled out over the next 3 years. That's a huge chunk of change, and it's one that hopefully can bring impact. But until the money gets on the ground, until the money gets in the hands of the people who are going to deliver healthcare, things aren't going to change. Money is only part of the answer. And there's other impacts that the Indigenous people are feeling, according to this study. And one is the continuing stigma and discrimination that they face daily and system-wide. It's a huge contributing role. Indigenous people don't trust the mainstream healthcare systems. They feel at risk at times. And if we think about some of the experiences we've heard in the media, I don't know how many of you recognize the name Brian Sinclair. He was an Indigenous man a couple of years back who sat for over 48 hours in an emergency ward in Winnipeg and succumbed from a treatable infection. Because we can only expect that perhaps the staff just thought he was another drunken Indian. And just recently in Northwest Territories, an elder was on the floor seeking medical help, and staff refused to send them for medical help because they assumed, again, he was just drunk. And by the time the family was able to convince the staff to seek medical help for this person, he ended up succumbing from stroke. Those kind of stories go like wildfire across the country. They inform how Indigenous people think about healthcare, inform how they expect to be treated by the healthcare system. How many of you have heard of the Aboriginal Healing and Wellness Strategy that happened here in Ontario some decades ago? Well, Oz, as it's popularly known, wasn't necessarily a political success. Healthcare in Indigenous the world is a complex issue of, sectoral and government entanglements that often get in the way. But one good thing that came out of Oz was the Aboriginal Health Access Center system. And these centers provide exemplars of how healthcare can be delivered for and with Indigenous people. In fact, the Oz model, which focuses on self-determination in healthcare, showed early results of change. A longitudinal study done related to Oz showed patients reporting their health experience as good to excellent at 60% of them. Whereas prior to the study, or rather, 86%, prior to that, the laws being implemented, only 60% were reporting a good experience, a good health. So we know the strategy works. And there's a combination of interrelated factors. As I've already mentioned, healthcare for Indigenous people is complex. And it's impacted by things like the residential school, colonization, oppression, discrimination, systemic racism. All these things continue to impact Indigenous people. And given the negative relationship that currently exists, organizations and agencies, such as the bodies that you all work for, have got to think about how they're going to realign, how they're going to change how they engage with Indigenous people. And we have to question, again, as I said earlier, the model. Does this model that we're using that works, we're changing, we're constructing, we're developing in the mainstream systems really work for Indigenous people? Can we just bring them in the big tent? I'm not questioning the guiding principles. I think your intentions are absolutely spot on. You want to affect change, you want to bring improvement to the patient experience for everybody in Canada. And that's a laudable and necessary undertaking, absolutely. But we have to understand, where does self-determination fit? How does that fit into how we engage with Indigenous people? And also, how does it happen? We hear lots about sovereignty, self-determination, and we all kind of scratch our heads and say, well, what's that mean? What's that mean on the ground? What's that mean in practice? And we have to ask, because the white paper on Patients First actually made that a priority. And here's a quote. This means the healthcare system must provide better supports and services for patients, families, and caregivers. And these are talking about Indigenous peoples here now. And these services must respect traditional methods and be culturally appropriate. And culturally appropriate is actually soft language. And I'm going to talk about how we get past being culturally appropriate. It's not enough. Well, there are examples. There really are examples of Indigenous healthcare and how Indigenous governance shapes that. Community-based governments, if any of you are familiar or part of the community health center systems, you know that community governance is part of that model. And in a talk I gave recently at the Association of Ontario Health Centers, I tried to describe the critical differences between mainstream governance models and Indigenous governance models. And part of what informs that is the holistic model of healthcare. So when AHACs are delivering healthcare, they're not just talking about patients. They're talking about the entire community and all the socioeconomic and social determinants are impacting that community and producing the health challenges that Indigenous people have, the barriers Indigenous people face, the terrible inequities that show up in healthcare for Indigenous people. And the AHACs actually currently provide healthcare to 26% of Ontario's Indigenous population. That means they're taking care of providing services to quite a few Indigenous people, but a lot of Indigenous people still are not getting access. And that's, I guess, thus the funding model that the government has announced. And that comes out of the Indigenous response to Patients First. That was the government response to it. Okay, we have to put more money on the table. We're not providing services to enough Indigenous people. So the services provided by AHACs focus on capacity rebuilding within communities, recovery of families, communities, and nations, and the provision of culturally safe healthcare. And it's not appropriate, it's safe. As I said to you, Indigenous people do not feel safe when they come into the mainstream systems. And so cultural safety is a key factor. It was wonderful to hear the group from Blue Water talk about the fact they've done the Indigenous cultural safety training. It's a critical first step to beginning to understand what needs to change. So the AHACs have outlined a strategic response to the white paper, and in fact the government was impressed enough that they have asked the AHACs to help them to sort out how to roll out that money, to help them put together a plan. So for one of the first times ever, Indigenous people are actually at the table ahead of time helping with the planning. And being at the table, being full participants, and having real authority in healthcare delivery is absolutely essential. They want to exercise the authority already acknowledged. Oz acknowledged self-determination in healthcare. Now we need to actually see that happen, get out of the way and let that happen. And here's some of the examples that come out of AHACs. Up in the North Shore area of here in Ontario, up in the Blind River Cutler area, Anishinaabe territory, there's the Mountain Western North Tribal Council, and Mininawa is the AHAC there. And they have a fully modeled health service. They're a regional healthcare provider. They provide culturally safe primary health care, as well as traditional health and healing, and mental health and addiction services. They have an overall regional management with community support services. They provide systems navigation, hospital discharge planning, and as well other home and community care services on and off reserve. And they've done that by partnering with local friendship centers, by using best practices and accountability, being accountable back to the community as a whole, and to patients, and of course respecting treaty rights and the rights to self-determination in healthcare as legislated here in Ontario. That's actually legislated, that Indigenous people have self-determination to healthcare. Up in Sudbury, Schmuckelcraig has a different model. But what they've done is they are integrating Western clinical practice with traditional healing models. And they use a symbol, a cultural symbol, the blanket, a woven blanket. They call it the woven blanket program. And through that model, they are developing a unique relationship with clients. There's no hierarchy there. The client is a full partner. Nobody gives the client orders. Nobody makes decisions on behalf of Indigenous clients. They fully participate in healthcare. Full participation. And there's no subservient, no superior in that model. It reflects Indigenous thinking. It reinforces a client-focused approach, certainly recognizes self-determination for clients, and at the same time helps to rebuild communities and family relationships because everybody's included. Over here in Hamilton, and Hamilton is an interesting case study because Hamilton is where the population study was conducted by Dr. Smiley. And the AHAC in Hamilton is already working in response to that data, particularly around the housing issue. I'm going to touch on that. They are participants in what's called Homeward Bound. Remember how I said that 2.8% of the population of Hamilton was Indigenous? Of the homeless population, 28% are Indigenous. 10 times. 10 times their population representation within homelessness. The program, the Homeward Bound, is a population data informed, and again, because of the study done, they were able to, the AHAC in Hamilton was able to provide solid information to help inform their strategy. And between April 2015 and April 2016, the Indigenous program housed 40 people. The clients were treated as members of a collaborative team working towards long-term solutions for them and their families. So this is not about providing temporary housing. This is about providing stability, to give breathing room, to bring change. Also here in Southern Ontario, where my partner is actually the Associate Director of the Southwest Ontario Aboriginal Health Access Centre, SOHAC. I know we're not supposed to use acronyms, but that's just too long. I have to use an acronym. And they're a fully accredited centre, accredited by the Canadian Centre for Accreditation. In fact, I was part of a team that helped to develop new accreditation standards, which were on stream when they were going through the accreditation process, but are now. But there are now standards for accrediting services to Indigenous people. And if you're being accredited by somebody else, then perhaps you need to talk to that agency, have them take a look at what the CCA is doing, and see how you can bring in accreditation standards if they're not already there. The services provided by SOHAC are inclusive and serves all self-identified First Nations, Inuit, and Métis, people of both status and non-status living on and off reserve. And that centre, which has five primary health centres scattered throughout Southern Ontario, in London, on Chippewa First Nations Reserve, now in Moravian Town, in Windsor, and in Owen Sound. And they have relationships. They're providing services to 36,000 Indigenous people in 13 communities. And let me tell you, compared to the regular healthcare system, they're doing it on a shoestring budget. And one of the things they focused on is providing a spectrum of services. They have 70 staff, and they provide physician care, clinical care, primary care, mental health services, and addiction services. They also provide a range of things, access to physiotherapy, chiropodists. There's a host of services. There are complex health issues, and the response needs to be comprehensive. In Toronto here, we have a Nationality Health. They've been around since 1984, and while their class is a community health center, they are unique in the fact that they are working to develop a traditional health model, to formalize that process of having traditional health workers available. And their model of healthcare is based on traditional Indigenous practices, approaches, and they're reflected in the design and delivery of programs and services. In fact, they are in the process of developing a whole new center on the lakeshore here. It's a few years off yet. They're going through an intensive community engagement around design, similar to what we heard from Saskatchewan, which is a remarkable story, I have to say, the Children's Hospital in Saskatoon. And so we will see change happening here in Toronto as well. And the population here, again, getting at the population of underestimation, official population counts here in Toronto puts the Indigenous population as low as some counts as 36,000. Well, the study done by Dr. Smiley, early analysis, indicates that may be undercounted by a factor of 3, which means we could have over 100,000 Indigenous people living in Toronto. There's only one Indigenous healthcare center in the city. 100,000 patients, one center, understaffed already. Could you imagine the challenges if you had a hospital with a handful of staff serving 100,000 people who have complex health problems? It's astounding. It can really set you back on your heels. So what do we do? Where do we fit in as non-Indigenous people? Where do we fit into that model? Where do we engage? And what I'm going to suggest to you is what we have to look at becoming allies. It's not about non-Indigenous people in the mainstream empowering Indigenous people. It's about supporting Indigenous people. Figure out how do we support what's already happening. How do we ensure that where we are providing services, they are culturally safe, and where it is appropriate that Indigenous people be providing the services, we don't jump in ahead of them and block them from that happening. I've seen it happen already. I've seen cases where Indigenous service providers will put together a proposal to a funding agency, only to learn later that proposal has been enacted, but nobody Indigenous is actually participating in it. It's been funded for mainstream health providers. So you're providing services which could be more effectively and more appropriately and more culturally safely provided to Indigenous communities and clients. So sometimes the most important thing we could do as non-Indigenous people is to get out of the way. It's a tough pill to swallow. We want to be helping, but it's something we really have to consider. When is that appropriate? As I said, there's a great deal of mistrust within Indigenous communities, and the history around that is not going to change anytime soon. We have to acknowledge that that's what's happening. We have to understand that change is going to come, but it's going to come very slowly. But there are tools that help you figure out where your place is in that. One of the ones I've talked about is Indigenous cultural safety training. There are others. There are reports that you can read to give you a better understanding of what's happening on the ground, what strategies are being utilized. One of the reports was the Indigenous response to Patients First. That's available online, publicly available, and anybody who's interested, I can provide a link to that. Dr. Smiley's research is also publicly available. I can provide you links to that. If you're in healthcare here in Ontario for sure, you have access to Indigenous cultural safety training. It's the first place to begin. It really is the first place to begin. It's online training. If you're in healthcare, it won't cost you a nickel, but I will warn you, there's a waiting list. There's a huge demand for this training. Everybody who's taken it tends to refer it to somebody else, most of the time. It's not easy to get through. I've worked with the Public Health Service Authority out of BC on this system. It's here in Ontario. It's being rolled out in Manitoba. And it really gets at the heart of what has to change. So if you want to find pathways to changing how Indigenous people experience healthcare, that's where I recommend you begin. Begin with the ICS training. It's available online. If you don't live in Ontario, it's still available because it's online. You may have to pay a fee. The basic course is $250. It's fully accredited training. The College of Physicians and Surgeons accredited it. It's nationally accredited. So as professional training, it's available to you. It's roughly 8 weeks to do it. You do it at your own leisure, your own time, and it's interactive, though not real-time interactive. It's really amazing training. And then you can read Dr. Smiley's research. I think it's really important you do that. One of the ones I recommend you read is her earlier work, which she completed through the Wellesley Institute, and that is First People, Second Class Treatment. And that will give you a pretty clear picture of the experience of Indigenous people across this country around healthcare. And her current work, I said, as an Our Health Counts, the Hamilton data is currently online and available, and I can provide that for anybody who's interested. There are other resources that I recommend you take the time to. I know you're all busy people and you may not have time to do this work. It's challenging. But if you are serious about trying to change, if you have a responsibility in your work to address this, then that's where you begin. Anybody have any questions?
It's phenomenal. It's really, really excellent. I recognize that it's around an approach of listening, participation, and so on, but I just wondered if you could, without being a cookie cutter, give us a couple of examples of culturally safe healthcare so that we can recognize when we see it and we can avoid it by not having it.
Well, I think the biggest thing.
It's a huge approach, but just
that's okay. No, I think it's not easy. This is not for the faint of heart. I will tell you right now. Making change of this nature is not for the faint of heart. One of the key things we can do is to stop being bystanders. We all see it. We see it every day. It takes courage to act. But stereotyping comes up as the single biggest common subject on these boards, and you probably remember from your doing the work. And so how do you go about changing that? Well, you know what? We all encounter stereotypes every day, and we have a variety of responses to them. We sort of turn away uncomfortably. We actually, for some, they'll accept it, engage and acknowledge it, and say, yeah, that's right. That's how Indians are. It's another drunken Indian. So we have to really begin to question our assumptions. So the first time you see an Indigenous patient is stop and think about, what's your gut reaction? How do you feel about this person? What are you feeling when you walk into the room and there's an older Indigenous man sitting there shaking and he's probably not well dressed? Or he may be very well dressed. Because one of the experiences that came out of the studies, you remember, was that often for Indigenous people, when they go into a hospital just to get basic care, they will put on the best clothes they own. Because you know what? If they're going in to advocate for mom or dad or someone else, they better dress up. Because if they don't, they're just going to be seen as a poor Indian. Oh God, what do they want now? And so we have to really ask ourselves, what am I feeling? What is my gut response? You know, it's not easy. And we have the question, what am I feeling? How kindness. You spoke about kindness. In Anishinaabe teachings, and within Haudenosaunee people as well, one of the greatest teachings is having a kind heart and having a good mind. So bear that in mind. Bring kindness to the forefront. When you approach that person, do it with kindness. Engage them. Don't jump right into the medical questions. Take time to get to know that person. You don't know them. And that's really important for somebody who feels very at risk, very afraid, and doesn't trust a white person or a non-Indigenous person.
Is there another question here? Or are we going to go to the computer? Let's finish off with this question, James.
So the question was, what are the challenges in bridging services and seeking collaborative efforts between First Nations, Chief and Council, and traditional healthcare providers?
That's a really important question, and that speaks to the inherent politics in healthcare. There's a real divide, and it's a legitimate divide because there's a great deal of misunderstanding in this country about our relationship with Indigenous people. Sylvia Miracle, who is the ED of the Ontario Federation Indigenous Friendship Centres, O5C, likes to remind us that we are a treaty people. We're all treaty people. This country exists only because of treaties. And so the First Nations leadership, Chief and Council, have a responsibility to their people to protect those treaty rights. And oftentimes they see relationships outside of the federal government as undermining and weakening that relationship. So it's a very difficult area. You need to build trust. Getting at that is going to mean that you need to find somebody who you can work with. You have to not run into, I got a program I want to deliver with you. It's, I want to develop a relationship with you. You have to introduce yourself to, you have to convince them that you're not out to exploit First Nations. So I can tell you right now that one of the concerns I've heard articulated by First Nations people is that they see themselves being colonized again by the healthcare system. Oh, guess what? There's $250 million coming out from the Ontario government. Where do we get a hold of some of that cash to put into our programs? And we've got to stop that. We really have to stop that. We need to begin to develop relationships. It may take you years. It may never be easy. It probably will never be easy. And sometimes you will fail to develop relationships because the barriers are so intense. I can give you an example of how difficult that can be, even for Indigenous people trying to change. In the Sohak region, there's a number of First Nation reserves, and in one case, one reserve had no relationship with the Lin or with Sohak, and they had just really backed away. And it came down to the fact that nobody had really ever taken the time to go there and develop a relationship with the Chief and Council. Most First Nations have a health care director. That will be your key contact person. If you want to talk about healthcare, you need to talk to the healthcare director to build that relationship first. And that's one place to begin, but it's never going to be easy, and it's going to be different with every community. The diversity in Ontario communities, Indigenous communities, is enormous. To give you an example, I worked up in Cree territory a couple of years back doing community engagement. And I developed a number of programs that were engaging Indigenous people to be more fully engaged in their own healthcare, to be partners in their own healthcare. And walking away from that afterwards and coming back down south, and because I've lived in an area of the last 5 years where I'm mostly in contact with Haudenosaunee people, though some of the Anishinaabe too, I realized very quickly that none of that would work down here. Everything I had done up in Moose Factory and Moosonee, up at Attawapiskat, for all that region, couldn't use it. The cultural differences are that significant. I could not use those programs. I could not use that approach. It just wouldn't work. And so you had to be prepared to learn about everybody, every community. There is diversity even within First Nations. It's enormous. Prior to the impact of colonization, there's enormous fragmentation within First Nations communities. And yet there's a desire. They desire, like all of us, I cannot but believe that First Nations want better lives for them. Indigenous people want better lives for themselves, their families, their children, everybody. There's a unique opportunity for us to change our relationship with Indigenous people in this country. But we've got to sit down and talk to ourselves and have what Southern America calls the hard conversations. We've got to be honest with ourselves, and we cannot honestly speak to ourselves what's going on within our own communities, our own service agencies. You know what? Nothing's going to change. It's not possible to change it if we don't begin changing ourselves first.